Hello, welcome to the second part of discussion regarding severe acute malnutrition. In the first part, we have seen about pathophysiology and the diagnosis of severe acute malnutrition in pediatrics. In this part, we will see management of severe acute malnutrition. When we first encounter a child with severe acute malnutrition, first we should have to take anthropometric measurement by ourselves and confirm the diagnosis of severe acute malnutrition. Then we should have to conduct ready-to-use therapeutic food appetite test for children from 6 to 59 months. And then we should have to conduct a medical assessment for a presence or absence of possible medical complication. Then we should have to refer the patient who fails appetite test, clinically not well and alert and has medical complication to the stabilization center or to healthy center. And we should admit patient with good appetite, clinically well and alert, minimal or no edema and no medical complication to the OTP or outpatient treatment center. All patients who are severely malnourished should be offered therapeutic feeding in one of the available settings, either outpatient therapeutic program or as inpatient. For outpatient therapeutic program, this provides service to children with severe acute malnutrition with good appetite and no medical complications. And on those sites, weekly follow-up visits at nearby health facilities needed in addition to the center. When we see the criteria needed to admit to OTP admission criteria, the first is bilateral pitting edema, grade 1 or grade 2, but not above that, or mid-upper arm circumference less than 11.5, or weight for height less than -3 on this score, and appetite test is passed, no medical complication, and clinically well and alert. Or if a child is referred from stabilization center after stabilization, this is a entry or a defined entry category for OTP admission criteria. When we see routine medications and the treatment that is given in outpatient therapeutic program, the first is antibiotic. Uh, from antibiotic, most commonly used is amoxicillin on admission in all severe acute malnutrition patients for 5 days, because almost all severe acute malnutrition patients are thought to have occult infection despite uh, having no symptom. The other is anti-malaria, if positive for malaria test, deworming after 1 week, and on the 4th week, giving measles vaccine if the child has not yet received the measles vaccine. And the other is nutritional rehabilitation, emotional and physical stimulation, the monitoring at OTP. While the patient is taking nutritional rehabilitation at OTP, we should have to follow them at local health center every week. On a weekly monitoring, we should have to send the patient to stabilization center if there is development of complications, weight changes, that means lose for 3 consecutive weight, and static weight for 5 consecutive weight, and edema, no reduction for 2 weeks or not resolved after 3 weeks, and grade 3 edema, and a severe wasting with bilateral pitting edema. You should have to send the patient from OTP to stabilization center. And also, if the child developed failure or poor appetite during the management at OTP, we should have to send them to the stabilization center. If a child is admitted to OTP with bilateral pitting edema, the patient should be discharged from OTP cured when there is no bilateral pitting edema for 2 consecutive visits, and MUAC is more than 12.5 centimeter, and the weight for height and or weight for length is more than or equal to -2 on this score, and the child should be clinically well and alert. And also there are a way to discharge uh, admitted patient to OTP based on their MUAC and the weight for height, as you see on this table. We should have to admit a child to stabilization center if they fulfill those criteria. Those criteria are bilateral pitting edema of grade 3, any grade of bilateral pitting edema combined with severe wasting, defined by MUAC less than 11.5 or weight for 8 less than -3 on this score, bilateral pitting edema, grade 1 or grade 2, or severe wasting if there is any medical complication. The medical complications are poor appetite or failed appetite test, interactable vomiting, seizure, lethargy, unconsciousness, high fever, lower respiratory infection, dehydration, severe anemia, hypoglycemia, hypothermia, severe skin lesion, or eye sign of vitamin A deficiency. Or if the patient is referred from OTP for stabilization. Those are a criteria to admit a patient to stabilization center for nutritional and medical complication management. During admission to stabilization center, we should have to treat medical complication and the nutritional rehabilitation. Stabilization center treatment and the care is divided into 3 phases: stabilization phase, transition phase, and the rehabilitation phase. On stabilization phase, we should have to treat medical complication like hypoglycemia. In a child with severe acute malnutrition, the level considered lows blood glucose level of less than 54 mg per dl. In this case, once we diagnose hypoglycemia, if a child is conscious, we should have to give 50 ml bolus of 10% glucose or 10% dextrose, either orally or by NG tube, and we should have to feed F75 every 30 minutes for 2 hours. If a child is unconscious or lethargic or having seizure, we should have to give IV 5 ml per kg of 10% glucose, followed by 50 ml of 10% glucose by NG tube, then F75 every 30 minutes for 2 hours, then every 2 hours. Then we should have to repeat the glucose test after 2 hours. The other is hypothermia. If the auxiliary temperature is below 35 degrees Celsius, the child is hypothermic. Most of the time, the most common cause of hypothermia in malnourished children is environmental cause. We should have to check the room of the child and also the clothes of the child. And we should have to prevent hypothermia as much as possible. And we should have to feed F75 straight away and rewarm the patient using either radiant warmer or any available one, or KMC caring, and check temperature every 30 minutes for the first 2 hours. The other is dehydration and the shock. In children with severe acute malnutrition, it is difficult to diagnose dehydration because the signs and the symptoms that we use to diagnose dehydration in non-malnourished children is not useful to diagnose dehydration in malnourished children. We should have to consider the diagnosis of dehydration in children with severe acute malnutrition when significant recent loss, clear change in child appearance, and the recent sunkening witnessed by the mother. And also if the child is edematous, weight loss more than 2% per day is a sign of dehydration. Once we diagnose dehydration in some, we should have to only rehydrate until the weight deficit either measured or estimated is corrected, and stop, do not give extra fluids to prevent recurrence. If the child is conscious, we should have to give rehydration solution for malnutrition, 5 ml per kg every 30 minutes for 2 hours, then 5 to 10 ml per kg once per hour, alternate with F75 every 30 minutes for 10 hours. If the child is unconscious or in shock, we should have to give IV fluids, ringer lactate with 5% glucose or half saline solution with 5% glucose at 50 ml per kg in the first hour, then reassess, and if improving, we should have to repeat it, and if not improved, we should have to stop it and assume as septic shock. So when we rehydrate a child with malnutrition, we should have to monitor weight. If there is weight loss, we should have to increase Rizomal by 10 ml per kg and reassess hourly. If the weight is the same, we should have to increase Rizomal by 5 ml per kg per hour and reassess every 1 hour. If the child is gaining weight and clinically not improved, we should have to stop all rehydration and give F75 and diagnose septic shock and give blood and dopamine. And if the weight is increasing but clinically improved, we should have to continue rehydration by NG tube or ORI with Rizomal. If the child is in shock, additionally, we should have to give oxygen and we should have to give fluid as we have said above. After giving 50 ml per kg over 1 hour, if the child improved, we should have to repeat it and continue rehydration via NG2 by Rizomal for 10 hours. If it fails to improve, we should have to consider other cause of shock as, for example, septic shock. We should have to give maintenance IV fluids 4 ml per kg per hour and search for blade and give 10 ml per kg whole blade over 3 hours or start dopamine. The other complication is severe anemia. Hemoglobin concentration less than 4 or hemoglobin concentration 4 to 6 and child is having congestive heart failure or severe respiratory distress, we consider as a child having severe anemia and consider transfusion. If available, we should have to give 5 to 7 ml per kg packed RBC to avoid CHF. And also, if a child is having CHF, we should have to always give packed RBC. Otherwise, we can give whole fresh blade 10 ml per kg over 3 hours. And for folic acid supplementation, the new preparation of therapeutic feeding formulation contains sufficient folic acid based on WHO specification to treat folic deficiency. So no need to provide additional folic acid nowadays. The other is infection in severe acute malnutrition. Typical signs of infection such as fever are often absent, and we should have to give a broad spectrum antibiotic routinely on admission for all patients with severe acute malnutrition admitted to stabilization center. And albendazole should be given at the start of rehabilitation or on day 7. These are the antibiotic choice based on the medical condition and also complication of a child. The other is about the issue of vitamin A. Vitamin A is nowadays not routinely given, and it is only given if there is severe acute malnutrition with high sign of vitamin A deficiency, or if the patient has recent measles now or in the past 3 months. Vitamins and minerals are present in therapeutic food that complies with WHO specification. Therefore, it is not necessary to give additional dose of these macronutrients. The other is about the feeding in children from 6 to 59 months. During stabilization phase, feeding should be started as soon as possible. We should have to start with F75. F75 contains 75 kilocalorie and 0.9 gram of protein per 100 ml. NF is defined as intake of 80% of the milk, and always we should have to monitor amount of intake. If a child has the following criteria, we can transfer a child from stabilization phase to transition phase. For example, appetite has returned, bilateral pitting edema is subsiding, there is no serious medical problems or no IV line. The child is ready to transit from stabilization phase to transition phase. During transition phase, we should have to introduce ready-to-use therapeutic food gradually along with F75. And when the patient is taking more than 75% of the amount of ready-to-use therapeutic food, such as pilampinate, we should be referred to OTP. In rare case, the patient should be transitioned from F75 to F100, and the volume of feeds remains the same. The patient should be moved back to stabilization phase from transition phase if there is weight gain of more than 10 grams per kg per day, along with respiratory distress, increasing or developing edema, a rapid increase in size of liver, tense abdominal distension, a complication that needs IV infusion, need for NH2 feeding, and a significant refeeding diarrhea. We should have to move a child from transition to stabilization phase or back to phase 1. Criteria to move to rehabilitation from transition phase is good appetite, edema reduced to moderate or mild, and if wasting with bilateral pitting edema should completely disappear. Medical complications are resolved. Clinically well and alert, you can send a child to rehabilitation or OTP. On rehabilitation phase or OTP, feeding is required to achieve very high energy intake and rapid weight gain of 10 grams per kg per day. And to achieve this, ready-to-use therapeutic food, or if 100 are used. And also we should have to provide sensory stimulation and emotional support. Failure to respond to treatment is defined by failure to gain appetite by day 4 after remission, failure to start to lose edema by day 4, edema still present by day 10, and the failure to gain at least 5 grams per kg body weight by day 10. So in this case, there is failure to respond to treatment, and we should have to consider the cause for this problem. This is all about management of severe acute malnutrition. Thank you for watching.